Hi, everybody. Thanks for joining us today at the Core Institute. I have the pleasure of talking today about heel pain. Heel pain is a very broad topic. For today's lecture, we will discuss specifically plantar fasciitis. So we'll discuss plantar fasciitis. We'll touch base on what other types of heel pain that may need to be evaluated or worked up if a person doesn't have plantar fasciitis. But we will have a follow-up lecture in a near future date regarding the other types of heel pain. But today we'll concentrate on plantar fasciitis. So just a basic anatomy lesson. The plantar fascia is a band of tissue that connects your heel bone to the base of your toes. As far as function is concerned, it helps support our arch and it helps absorb some shock when we walk. It doesn't have a huge function, but that's what it does. The majority of the time, when basically plantar fasciitis is inflammation of the plantar fascia, and a common scenario is that there is not a traumatic event that causes plantar fasciitis. A person can have a traumatic event, but the majority of the time it just shows up out of the blue. There's a common comment by the patient. Most patients are baffled by this, but what most people don't realize is that this is something that has been developing over an extended period of time, and that at a moment in time it kind of hits a boiling point and it becomes symptomatic. So again, just a little diagram here showing the plantar fascia extending from the base of the toes, the ball of the foot, to the heel. The majority of the time when a person does have plantar fasciitis, it is near its origin at the heel. A person can have pain in the arch as well, but again, today we're concentrating on the heel pain. Just another diagram. Okay. So inflammation of the plantar fascia. Again, most of the time it's inflamed where it attaches to the heel bone. Essentially what happens is there is too much pressure or too much work of the plantar fascia, which causes small tears, which therefore creates the inflammation. And this can turn into a vicious cycle of pain that can be hard to get rid of. It is the most common cause of heel pain. 10% of the U.S. Adult population will have some type of plantar fascial pain each year. That's a lot of people. Over 1 million visits to a physician per year for this problem. And estimated medical costs, depending on the studies, are anywhere from 192 to 376 million dollars per year are spent. Medical dollars are spent on treating this problem. It can occur in both sedentary and active people, so no one is immune to this problem. Often this problem turns chronically inflamed. It becomes a chronic issue. It can be very difficult to resolve quickly. Even during treatments, plantar fasciitis can last 10 months, sometimes longer, and sometimes it can be a self-limiting condition as well. So risk factors. Again, there are some risk factors, but really nobody is completely immune to this. Everybody can get it, but it can happen again. All types, high arches, low arches, a person that is overweight, a very fit person. Commonly, it happens in athletes, especially with repetitive, high-impact activities, runners, jumpers, dancers, people who work and stand at work for prolonged periods of time, exercising on hard surfaces, exercising without stretching or loosening their calf muscles. Poor shoe choice is a major issue. Essentially, there's an overuse and wear and tear of the plantar fascia. Common age group, again, everybody can get it, even teenagers, people in their 20s, but the majority of people, the largest grouping of people between 40 and 70. And often there are biomechanical issues, which we'll touch on, that lead to the development of plantar fasciitis. Again, the frustration associated with plantar fasciitis is real. It's a real thing. When people come into the office, they're often have already been dealing with this problem for several months. So it can be very frustrating, especially because there is no obvious injury. It can make a person miserable. It can affect their work and social life. Often people are trying to get into shape and exercise, but the pain that they're experiencing does not allow them to do so. Often we will see a person, it's a common scenario again, that a person may have had this problem years ago, and at that time it was resolved very quickly. But it seems each time a person develops plantar fasciitis, it can be a little more stubborn. A common question that people ask, well, how come I only get it in one foot and not the other? It's an excellent question, but it's actually the most common scenario. So only about 30% of people, or a third of people, will have it in both feet at the same time. A great frustration, a cause of frustration for people dealing with plantar fasciitis is the too many chefs in the kitchen scenario. It's such a common problem. So many people have had this problem that we really receive a lot of input from family and friends of, giving advice. And there's nothing wrong with the advice, but what leads to frustration is that often, most of the time, every case is unique. So what has worked for one person isn't necessarily going to work for you. And again, even during treatments, it can last several months. So symptoms associated with plantar fasciitis. Typically, a person has pain at the bottom of the heel or near the heel. The pain can be characterized as stabbing, throbbing, sharp, aching, or a lot of times people will say it feels like there's a hot poker in the bottom of their heel. A common symptom, in fact, it can be diagnostic for plantar fasciitis, is pain with the first few steps out of bed in the morning, or if a person is sitting for a longer period of time and they go to get up, their first few steps can be extremely painful. A person can experience pain after activity or exercise. The pain can also increase by the end of the day. It can become more painful. And again, a person can have pain in the arch as well. The plantar fascia extends, of course, through the arch. So examination. The diagnosis made by physicians is based, just like many other things, on medical history and physical exam. A symptom, once again, is once a person says they tend to have pain out of bed in the morning or their first few steps, that kind of leads us down a path towards ruling out or working up for plantar fasciitis. It is necessary to palpate the area, feel the area. We have to rule out some other causes of heel pain during the examination. But your doctor will check how your feet work, such as biomechanical issues, your foot structure, your gait pattern, which goes back to the biomechanical factors, whether or not a person has tight Achilles tendon or calf muscles, and x-rays are typically taken as well. So other causes of other problems that may mimic plantar fasciitis include tarsal tunnel syndrome, stress fractures, or bone cysts, or other types of nerve entrapments. These topics, we'll touch on them briefly, a couple of these here in the next few slides, but we'll discuss these more thoroughly in the lecture, the future lecture. So again, the plantar fascia, essentially what happens is near its attachment to the heel, there's chronic inflammation. When there's chronic inflammation, the plantar fascia, in this case, we're talking about plantar fascia, but it could be other soft tissues in the body as well. When there's chronic inflammation, it tends to weaken. And because we continue to walk on it, little splits or tears can develop in the plantar fascia, and this is what causes the pain. Again, a person, the diagram or the picture on the right is showing someone palpate the area. The diagram on the left is showing area that, typically at the center to inside half of the heel is where a person experiences pain. A person can experience pain also on the outside of the heel, but it's not as common. And again, a person can experience pain into the arch. So, why are x-rays taken? Quite often, a person will come into our office and say, oh, my primary care doctor said I had a heel spur, or I think I have a heel spur. And as foot specialists, the last thing we're looking for is a heel spur. The heel spur itself is not the cause of heel pain. Many people, because they have that hot poker sensation, or it feels as if they're walking on a sharp object, but in fact they're not. 1 out of 10 people have heel spurs on x-rays, but only 1 out of 20 people with heel spurs has foot pain, if that makes sense. So a lot of times we'll see a person for another problem. Maybe they're coming in for a bunion deformity, and we take x-rays and we'll see that they have a heel spur. And just out of curiosity, sometimes I'll ask the person, have you ever had any heel pain? And they'll say never, but they have a huge spur. So it's not the spur itself that causes the pain. And this is important because a person has to realize that they can have complete resolution of pain, even if the bone spur is present. So psychologically, sometimes when a person knows they have a bone spur, it can be counterproductive to them, in some people, to getting better, because psychologically they can't get past the fact that they have a spur. But what we're really checking for when we take x-rays is, number one, we're checking how the foot bones are aligned when you're standing, and we are checking for other problems such as a stress fracture or bone cysts. So as foot doctors, often a person will bring x-rays with them to the office, which is fine. But if the x-rays are not weight-bearing x-rays, they really aren't helpful to us. So they may be helpful in ruling out stress fracture or a bone cyst, but they're not helping us as far as their foot structure when they stand. And that's how we really know how we find out how we can help a person. So if they're not weight-bearing, they're not of a great use to us. So this x-ray shows the bottom of the heel, and you can see the heel spur right here. The heel spur itself, a lot of times the heel spur itself is parallel to the weight-bearing surface. So it's parallel to the floor or the platform. It's not pointing downward. So we're not walking on the heel spur. The plantar fascia comes in and it attaches, if you follow the cursor, it attaches to the bottom of the heel right there. And what happens is, as it swells and as it becomes inflamed, it becomes thicker and it rubs on the heel bone, and this is what creates the formation of the spur. This diagram right here shows this, you can see this empty area right here. This is called a bone cyst. Bone cyst any type of cyst, whether it's a bone cyst or a cyst in the soft tissue, is filled with fluid, and that bone cyst the fluid within the cyst can become painful, and this can create heel pain. On the bottom X-ray, you see this bright white line right here. This person has heel pain, and this white line is a sign of a stress fracture. So treatment for a stress fracture is much different than, and a bone cyst is much different than that of plantar fasciitis. So these are the reasons we take the X-ray. Sometimes an MRI is needed, but it's not very common. Also, other imaging that can be done is an ultrasound. And often an ultrasound can be beneficial when a person isn't responding to basic treatments. Often your foot doctor can perform the ultrasound right in the office, and we can show you what the plantar fascia looks like. And basically, what we are looking for is we're looking to see how inflamed the plantar fascia is. And depending on how thick the plantar fascia is or how inflamed it is, that sometimes there have been many studies shown that can be it can predict whether or not what a person's chances are with getting better with conservative treatments. So this is an MRI, and the MRI here, if you see this black line working our way, so we can see this thin black line right here, that's the plantar fascia, but as we get closer to the heel, we can see how that black line is now wider, and that's showing inflammation of the plantar fascia, and you can see where it attaches to the heel bone right here. This is an ultrasound. So basically what we're looking at, this black area right here is the heel bone. We're looking at the foot, it's upside down. This is the fat cushion, and this band of tissue, this wavy-like tissue, is the ultrasound. And we can see that the plantar fascia here is fairly narrow, and on the other side, it's fairly narrow. But right here, it's pretty fat, it's pretty thick. So it's 0.83 centimeters thick on this ultrasound, and this is what we're looking for. And there have been many studies shown, many studies over the years, that if the plantar fascia is greater than or equal to 0.6 centimeters, a person's going to have a hard time getting better with conservative treatments. So treatment basics. So basically what we want to do, if we just start up here, is the first thing is we want to reduce or resolve a person's pain. And so doing so, we need to reduce the inflammation. And oftentimes we need to eliminate the irritating factor, which are the biomechanical problems. So we need to support the plantar fascia a little more so it doesn't have to work as hard. And then what we also want to do, my goal as a foot doctor, is I want people to be able to maintain the activities they enjoy doing and get better at the same time. So when you first come in, the majority of the time, I want you to try, with some changes that I recommend, I want you to try to participate in the activities that you enjoy. If down the road we see that that's not working, then sometimes we have to modify activities. But this cycle often has to be repeated for several months. As I mentioned earlier, sometimes this problem can last several months, so it could be frustrating. So treatments. Of course, rest is the #1 treatment. It doesn't matter if it's a plantar fascia or a tendon or an inflamed joint. The best way to help the inflammation improve is to rest that area. Again, activity modification. If you run or you do other high impact activities, it's not a bad idea to try something else, biking, swimming, and so on. Non-steroidal anti-inflammatories such as ibuprofen and others often are necessary, as is ice. Stretching is extremely important, as is something we refer to as a plantar fascia splint, which can also be referred to as a night splint, and we'll touch on that. For plantar fasciitis, I cannot underestimate how valuable physical therapy is. So physical therapy is an extremely important treatment regimen modality for plantar fasciitis. Often a person needs arch supports, which are also known as orthotics. They can be pre-made or they can be custom made. And again, that's something that your doctor will discuss with you. Shoes are an extremely important factor as well. Many shoes, often I'll have a person come in and they'll tell me, well, I spent $150 on this pair of shoes. It's a great pair of shoes. And really the cost is not important. It's the structure of the shoe, which we'll talk about. Most shoes, when a person is dealing with plantar fasciitis, the shoe itself does not have enough arch support in it. Many times people feel they need cushions, so they think memory foam is a good thing, and it is counterproductive. And believe it or not, sometimes shoes with a slight elevation in the heel is very beneficial. And then sometimes a person may need to have cortisone injections, which is an anti-inflammatory delivered right to the area. Again, too many chefs, it can be a very frustrating problem. Every case is unique. And believe it or not, approximately 95% of, again, depending on the numbers vary, a point here and a point there, but approximately 95% of the people who develop plantar fasciitis will get better without surgery. There are a few people that will end up having surgery. So let's go to plantar fascia splint. So plantar fascia splint, so basically with the plantar fascia splint, there are different variations. The plantar fascia splint is meant to, it's not a walking splint. On the right, we have something called a Strasburg sock. And this is the one in the middle is a little variation of a Strasburg sock. And the one on the left is a plantar fascia splint. But essentially what it does is, without you actively stretching out your calf muscle, it helps stretch out the calf muscle. And then also with plantar fasciitis, what happens is during plantar fasciitis, when a person is dealing with plantar fasciitis, the plantar fascia is essentially confused. It's not being supported enough, so it's straining too much. Then when we come off of the plantar fascia, it's angry, so it starts to tighten up and knot up. And that's why when it tightens up or knots up, that's what causes the severe pain when you get out of bed in the morning or if you sit for a long period of time. So the plantar fascia splint helps stretch out the calf muscles, and it also helps train that plantar fascia just not to tighten up or knot up anymore. It's trying to teach it to calm down a little bit. This is, I would say, the plantar fascia splint. I'm actually, I'll be honest with you, I'm shocked at times how many times a person comes in to see me that has had plantar fasciitis and they've seen multiple specialists and they've never been told to use a plantar fascia splint. So it's one of the most important treatment modalities, in my opinion. So arch support. So the plantar fascia splint is training the plantar fascia not to knot up and not to tighten up, but sometimes we also need to support the plantar fascia, and that can be with orthotics. These are samples of orthotics. There are custom orthotics. There are very good pre-made orthotics as well that we can point a person into the right direction. But what's important is the arch support itself is not supposed to give a person more arch. That's really not the purpose of it. The arch support is just to help maintain what arch a person has, even if that's a very low arch. And it's just for the purposes of plantar fasciitis, we are trying to support the plantar fascia so it doesn't have to strain as much. On the left side, this is just showing that the shoe itself needs to be able to accommodate an arch support. Shoes. So what to look for in a shoe. One of the most important factors is a stiffer sole. So I have a little foot model here. I'll show you what I mean. So basically what happens is, if you can see my little diagram here, again, the plantar fascia is anchored to the heel and it goes out towards the ball of the foot, to the ball of the foot. So what happens is, of course, when we take a step, the heel comes down and then we go to the ball of the foot. And of course, the joints at the ball of the foot bend. But in a person who wears a very flexible shoe, when we continue to walk and take a step, the foot actually bends like this. And if the plantar fascia is attached to the ball of the foot and it attached to the heel, when we get that bending force in the middle of the foot, the plantar fascia is stretching too much. So when a person wears a stiffer soled shoe, when the heel comes down and then the ball of the foot comes down, because the shoe is stiffer, when they go to take a step, they don't get that bending force. So the stiffness of the shoe is very important, and it can be a sandal as well. We know, and we'll talk about sandals in a little bit, but stiffness is very important, and it must be able to, the majority of the time, be able to accommodate an arch support. Again, flexible sole is very bad. Memory foam isn't necessarily helpful and sometimes counterproductive. But again, people feel as if they need cushion in their heel. So it makes sense. It makes logical sense because of the type of pain that they're experiencing. But again, the arches need support more than they need cushion. Again, it's not about the brand or the cost of the shoe. This is a common conversation that I have. People come in with bags of shoes, probably thousands of dollars worth of shoes, and they're lucky sometimes to have one pair of shoe that is good for their problem. So it's about the structure. And again, believe it or not, a slight heel, for those of you who like to wear sandals and wedges and so on and so forth, a slight heel or a little wedge is often good because, again, when a person's standing flat, the arch is straining, but which increases the tension at the heel bone. But if the heel is elevated a little bit above the ball of the foot, it releases the tension of the plantar fascia. So often I'll ask them, especially during the warmer months, I'll say, how do you feel when you wear a wedge? And they'll think about it for a couple of seconds and they'll say, actually, my foot feels a little bit better. And it's not because they're taking pressure off the heel. Basically, what they're doing is they're releasing the tension of the attachment into the heel bone. Shoes. So these are just some samples. Again, you need a shoe that accommodates an arch support. There are many brands. I'm not endorsing these brands, but these shoes all have a stiffer sole, and that's what's important. You have a little wedge here. This sole, it doesn't bend. It's as stiff as can be. And a lot of times in a person with plantar fasciitis, this will feel really good to them. There are actually sandals and arch supports that you can purchase now that have stiff soles. They're not the old traditional flip-flops, and they have some arch support in them, so they can be very beneficial. Flexible shoes are bad for this problem. Again, a common scenario, a person comes in, they'll tell me they've been dealing with this problem for 12 months, and they'll have these very flexible shoes on, and I'll look at their shoes, and the first thing they'll do is they'll say, but those are so comfortable. So it's this vicious cycle. Their feet are in extreme pain, yet they feel that the shoes are comfortable. So very flexible shoes are bad for this, bad for a lot of problems, but since we're talking about plantar fasciitis, we'll just stick to that. Stretching is very important. So the stretching often is aimed at loosening up the calf muscles, often just from normal daily activities, even in people who don't exercise, just normal daily walking, our calf muscles tighten over time, or people have congenital tight calf muscles. Trying to massage or loosen up the plantar fascia, again, to try to get the knots out, so to speak, can be very beneficial. So there are a lot of products we can point you towards. Physical therapy. So physical therapy for many things, but again, we're talking about plantar fasciitis. It can be extremely beneficial. It has been proven time and time and time again that it speeds up recovery for plantar fasciitis. It can help prevent reoccurrence for plantar fasciitis because a person becomes educated of what they need to do, and they can be directed to proper treatment modalities. Physical therapy will evaluate and can help correct biomechanical imbalances and or weaknesses, your gait and posture, and they can also help with shoe recommendations and so on and so forth. The physical therapists can often, based on their evaluations, help the treating physician switch things up a little bit and see something that they weren't seeing, and we can address it. So this is just, physical therapy can do so many things. The bottom is what we, an arch strapping. It's sometimes called a low dye strapping, and this picture on the bottom is using kinesio tape. But a lot of times, during treatments, a physical therapist will put this on, and this helps support the plantar fascia, and it can simulate an arch support. So it's a very important treatment modality. The picture on the top with that metal instrument is a physical therapy technique where basically the physical therapy, again, is, for lack of a better term, is working the kinks out or getting the knots out of the plantar fascia with deep tissue massage. So a lot of times people think physical therapy is just stretching or this and that. It's not. You have to have open mind. I mean, physical therapists also there are many, I can't touch on them all in this lecture, but they have treatment modalities that help reduce plantar fascia, inflammation of tissues of the plantar fascia, such as therapeutic ultrasound and laser therapies and light therapies, and there are all kinds of things that physical therapists can do. They have all kinds of tricks in their bags for this problem. So often, let me go back to physical therapy. Well, this is a good one. Don't be resistant to it. So it helps. Let's just think of a high-level athlete, okay? So think of a professional athlete. How many professional athletes throughout whatever sport they play, the season that they have, are going through? I can't imagine the number of them that have plantar fasciitis. It's got to be high. But I guarantee they're staying on the field or the court or whatever it may be, and the people that are helping them do that are the physical therapists. Cortisone injections. Cortisone injections are a tool. They're not a silver bullet. Oftentimes people will come in, and if a cortisone injection is maybe recommended, the first thing they say is, that's just to mask the pain. It is not masking pain. If you get a reduction in pain from a cortisone injection, it's because it's reducing the inflammation. The pain for plantar fasciitis is caused by inflammation. If the cortisone, so it's not a pain pill, so to speak, but it may, it's just a tool. In order for the cortisone injection, you have to set it up to succeed. You may not need it at all, but you have to set up the cortisone injection to succeed. And the best way to do that is with the proper shoes, the proper support, and all of the modalities that we've discussed already. And especially because it's the bottom of the foot, it's not unusual if a person was to have a cortisone injection or require a cortisone injection. It's not unusual for a person to need more than one. If you think about it, it's meant to reduce inflammation, but the inflammation is on the bottom of the foot. So as soon as a person receives the cortisone injection, as soon as they leave the office, they're putting weight on the foot. So the cortisone sometimes has an uphill battle for plantar fasciitis, and this is why sometimes, and other foot issues, this is why at times a person may require one. So the plantar by the time we see a person in the office, usually the plantar fascia is chronically inflamed already. And basically, chronic inflammation is, with inflammation, with an injury, there is a healing cycle. So with plantar fasciitis or different types of tendonitis, the healing cycle when the injury occurs, such as an overuse injury or a wear and tear injury in this case, overuse or wear and tear, instead of going on to complete healing, it gets stuck in the inflammatory phase, and this is what causes the pain. And sometimes we need to be more aggressive, and we need to jumpstart the healing process. We need to jumpstart the inflammation to turn it back into an acutely inflamed piece of tissue to restart the healing process. And so basically, when this little diagram, not to get too deep into the healing cycle, but when something is first injured or first becomes painful, there is this inflammatory phase that is natural. And then, but it just typically, the inflammatory phase is just a few days or so. And then it moves into the repairing phase and then the remodeling phase and so on and so forth. But the inflammatory phase often is just a few days. But with plantar fasciitis, it gets stuck in inflammation. It never moves out of the inflammatory phase. So sometimes we have to be more aggressive with plantar fasciitis. Sometimes we need to tell a person they can't run anymore for a while, or we need to put them in a walking boot, or we need to put them in a cast. There are other modalities such as platelet-rich plasma injections or shockwave treatments that can help jumpstart the healing cycle. This is a sample of a walking boot and a cast. So shockwave therapy. So shockwave therapy basically uses shock waves, and it is an FDA-approved treatment for plantar fasciitis. It is a non-surgical treatment option, and basically what it does is it sends shock waves to the area of discomfort, and what we're trying to do is we're trying to create an acute injury again, trying to turn that chronic inflammation into an acute inflammation so it can continue on to healing. It's often approved in the office, and performed in the office, and there's no anesthesia required. Typically, there are no limitations. Once a person receives the shockwave treatment, they can do whatever they're comfortable doing, although a walking boot or taking it easy for a few days can be beneficial and makes a lot of sense. It's not unusual for a person to need more than one treatment, sometimes up to 4 treatments, sometimes at 1 to 2 week intervals. The issue with shockwave treatments is that it is not typically covered by insurance, and typically the fee is paid that covers an agreed upon number of treatments. But typically, this is an option for someone who wants to avoid surgery. So this is just this is the unit right here, and we can dial up what strength of the shock wave. This is actually a unit that we have at core, is very similar to the unit we have at core, and this little head, and it's literally like turns the plantar fascia into a little punching bag. So that's what it looks like. It's done right in the office with a little ultrasound gel. Then there are plasma-rich platelet injections. There's a misprint here, I apologize. So it's plasma-rich platelet injections. So basically, platelets is part of our blood, of course, and they have an important role in soft tissue regeneration and repair. The injection of platelets into an injured area helps promote healing. Essentially, what happens is a person has some blood drawn, just like they would if they were having a blood draw at the lab for some blood work, but they have some blood drawn in the office, and then that blood is put into a tube and it's spun in a centrifuge. And what it does is it separates the components of the blood. But then the platelets are taken and they're injected into the painful area. And I'll show you a picture here in a second. Again, this is not something that is typically covered by insurance. It's something that may require more than one treatment, and often the area requires to be numbed before we perform the injection. So essentially, as we all know, blood is red, but this shows blood, this shows the plasma, this yellow liquid. It's already been spun in the centrifuge up here, and now this is what remains, and this is what is used to inject the plantar fascia to stimulate healing. So other treatments. So other treatments for plantar fasciitis, again, massage. There are a lot of treatments. We can't even cover them all in this lecture. I don't have enough time, but just to touch base, so often people talk, is acupuncture an option? Is dry needling an option? Is massage therapy an option? They're all options, and they've all helped some people. So there aren't any, most of the time, there aren't any problems with trying those options for stubborn cases. Surgery. Again, only about 5% of patients with plantar fasciitis will go on to have surgery. Often people are very resistant to surgery, understandably so, but it's one of those problems that, again, can hamper a person's lifestyle, and for many people, again, only 5%, but it's 5% of a large number of people, a large number of patients that have this problem. So it's therefore a lot of people. But success rate is, again, these are many studies. These aren't my numbers. These are many studies. It's 85 to 90% overall success rate for the different types of plantar fascial surgery. Endoscopic plantar fasciotomy has a success rate of 90%. And a realistic goal following surgery is return to full activity. Whether a person needs surgery or not, the number one goal is, other than resolution of pain, the most important outcome is that a person is able to do what they enjoy doing. So the goal should be no less than that. So just to touch base, again, the shockwave therapy and platelet-rich plasma injections, those are, after we do the conservative treatments, those are options that are available for a person to try if they choose to, and short of an actual surgery, but then we're to the surgery end of the treatment spectrum now. Types of surgery, there are many types of surgery, but the types of surgery include an endoscopic plantar fasciotomy, an open plantar fasciotomy, or a Tenex procedure, or a Topaz procedure, and then there's also something called gastrocnemius recession, which sometimes is a treatment in and of itself, or in addition to these other procedures. Most of the time, regardless of the type of the surgery a person ends up having, most of the time a person can perform protected weight bearing right away in a boot or a cast. There may be some instances when non-weight bearing is recommended for a short period of time, but typically the weight bearing, the protected weight bearing in a boot or a boot is at least for 6 to 8 weeks. Again, the piece of tissue had been chronically inflamed for many people for several months by the time they end up having surgery, sometimes a couple of years. So then we make it angry with the surgery. So the best thing to do is to try to protect it and let it calm down. But rigorous activities, high impact activities, often minimum of 3 to 4 months before people can get back into those types of activities. So the Tenex and Topaz procedures, Basically, with the Tenex and Topaz procedures, again, it's a surgical procedure. Often, not all the time, typically not covered by insurance, so there can be a high cost associated with it. Sometimes the procedure needs to be repeated, but basically what is done is that a special instrument is used that breaks up and removes portions of the plantar fascia in order to stimulate healing. So basically, we see these instruments. Of course, the surgeon right here is the handle, but it looks like a little needle or a long thin instrument. You can see a little better here on the bottom right. And basically what's happening, you can see the doctor in this case has marked a little grid here, like a little checker board. And basically what's done is this instrument is poked in and out into the plantar fascia in this grid-like fashion. And what that does is it's trying to remove some of the damaged plantar fascia to stimulate healing. On the bottom left here, this is an ultrasound being performed intraoperatively, and you can see the instrument coming in right here. If you follow my cursor, you can see the instrument, and it's basically poking in. This down here is the heel bone, the calcaneus, but this band of tissue is the plantar fascia, so it's poking in the plantar fascia. So the doctor goes in and out with that instrument. Open plantar fasciotomy. An open plantar fasciotomy is just what it sounds like. It's a larger incision, but with the larger incision, we can directly visualize the plantar fascia to release the portion of the plantar fascia. And sometimes the incision is made on the side of the heel. Sometimes the incision is made on the bottom of the foot. And essentially what's done is the plantar fascia is just incised. So often people ask me, well, do you release it all? Is it released all the way across? And the answer is no, it's not. It's just released essentially from the center of the heel, right here. If you split the heel in half, from the center of the heel to the inside half. Okay, so the inside 50% or so. So I have a little diagram here. It may be hard to see. I don't know if it is, but can you see that all right? But basically what happens is we have these two little bumps on the bottom of the heel bone called tubercles, and the plantar fascia attaches to both of them, but we release only the inside half of the plantar fascia. This is an endoscopic plantar fasciotomy. It's the one that I do most often when it's required. And basically, it's an endoscope. Just you've heard of endoscopic procedures, just like other procedures. And you have a small little incision on each half of the heel, and we put this tunnel called a cannula. And then in one end of the tunnel, we put a camera, and the other end of the tunnel, I use a little instrument, and I can visualize the plantar fascia. It's on a screen that I'm watching while I'm doing the procedure, and I release the plantar fascia. This procedure literally takes 10 to 12 minutes. It takes longer to get ready for the procedure than to actually do the procedure. And then again, the incision on each side of the heel is approximately 1 centimeter long. And you have 1 to 2 little sutures in each of those incisions. Well, can I walk, function normally if a portion of my plantar fascia is released? I can't say it any simpler than this. Yes. I mean, this question is asked over and over. It's a very good question. It's a very practical question. But yes, you can. Sometimes, so again, going back to professional athletes, most of us aren't professional athletes, but professional athletes, high-level college athletes can have this procedure performed, and they don't have to quit their careers. They don't have to retire. So if they can do it, we can as well. Sometimes after a person has this procedure performed, again, depending on their foot structure and so on and so forth, sometimes we definitely need to maintain when they're performing their athletic activities an arch support in their shoe. So plantar fasciitis can be a real pain, of course. It can be an extreme, it's probably out of all of the problems that I treat, it's probably one of the most frustrating problems. From the onset of treatment or seeing your foot doctor, the more aggressive you are, the better chance you have of getting better. And when I say aggressive, I don't mean surgery. I mean making sure your physical therapy, anti-inflammatory, arch supports, plantar fascia splint, basically throwing the book at it. You definitely have to have the mindset. The first thing that I talk to people about is getting in the mindset. And I would love to be wrong, but the majority of the time it can be a long haul. So you kind of have to get in the mindset that it's going to be a little bit of a battle, but you will definitely get better. And again, that goes into having realistic expectations. Um, having it for 18 months and then coming in 2 weeks before you go on a vacation and expecting it to be gone, it's not a realistic expectation. Um, and again, part of the frustration is because there's so much information on the internet, there is a lot of good information, but again, it's from family and friends that are giving their advice. And it's very, very, it can be frustrating because we start thinking, well, my friend said they put an arch support in their shoe and they got better in a week. But that happens for some people, thank God. But some people it doesn't, and the majority of people it doesn't. So just keep that in mind.